Hi, hello everybody. So my name is Dr. Walia. I'm the San Ramon stroke coordinator. Unfortunately, if we're watching this video, if you guys are watching this video, that means I didn't quite make it back to the country in time. I actually took a vacation with my family out in Europe, but unfortunately early this morning, my plan was actually to land early this morning and come to the nursing education, which Stephanie is probably doing a great job putting together at this time. But unfortunately, my flight was pushed back. So right now I'm sitting in a hotel lobby recording this for you guys. So at least we can provide you with some education, or the education that I intended to provide you, hopefully in person. I know it would have been better in person, but obviously, luckily with technology and things, there was something hopefully that we could do. So let me just start by introducing myself. I'm Dr. Walia. I am the new San Ramon stroke coordinator. Just a little bit about myself, just because, I'm new to San Ramon in of itself. I was born and raised in the Bay Area. I'm from Fremont. So somewhat local, just recently moved to the San Ramon area as well. Grew up in Fremont, did a lot of my high school in Fremont, then did a lot of my training for medical school in Georgetown, UC Davis, and then finally Stanford. But as of May, we have started to work at San Ramon. The idea, and we've been quite pleasantly surprised with, the nursing ability there, the stroke program there. And then we were brought in with the intention to slowly but surely analyze the stroke program and still slowly, continually build that program and bring it up to par with, some of the other leaders in the nation as stroke literature is getting better and better and better. So I think one of the most important aspects of that is essentially you all, or the nursing, which pretty much enable everything that we try to accomplish on the floors goes through you guys. So the more that you guys know and the more, educated you guys are, I think it's better for the patients and also better for our whole team. Dr. Yazbek and I are the two neurologists in our group. Hopefully you've seen us around at times rounding, seeing patients. So both of us split coverage. So, anytime that you have any neurological patient, not just a stroke patient or any neuro disease, usually we'll be consulted. We'll see the patient and, stop us if you have questions. We're happy to talk. We think that we're quite nice. And so we'll go from there. So the purpose of my talk today was essentially to go over parts of the NIH stroke scale, mostly from a clinical perspective, what you guys should be watching for, how you guys should communicate things, what you guys should be asking of us. Also some nuances of the examinations, some stuff that I consider helpful, and then putting it all together kind of clinically to kind of understand why certain things are important and why other things are not as important. All right. So this is kind of what I want to go over. So one is quite brief, just the history of the NIH stroke scale. And again, why we use it, how it should be communicated. And like I said, going through the nuances of the examination. Forgive me if there's a lot of noise. It's just like a hotel lobby. So hopefully, there's not going to be a lot of interference here. All right. So a little bit of background about the NIH stroke scale. So it actually, there's nothing special. I mean, NIH is just National Institute of Health, which is a place in Washington, D.C. that does a lot of these large scale studies, not just for stroke, but all over. They're quite regarded as a high level institution for development of literature. So the NIH stroke scale is essentially a widely used systematic tool designed to measure neurologic deficits. So it actually originated from the NIHSS trial, which is there in purple. So the NIHSS trial was as the actual trial that came out originally, that back in the day, we didn't really have much to offer stroke patients at all. They would just, sit there. People would say, okay, you're having a stroke. We don't unfortunately have any treatments for this. But the NIHSS trial was the first trial that actually verified that TPA was effective and got approval for TPA as a FDA approval eventually for TPA as the approved medication for acute stroke within the 6-hour window mark. And so during their trial, they wanted to measure, okay, were patients were getting better or were they getting worse before and after receiving TPA. You obviously wanted to measure how patients were at the beginning, during, and after getting TPA infusions. And what they actually developed in their trial, the NIH stroke scale, which was a way to actually validate whether there was like improvement, like the patients improved or did they deteriorate after getting TPA. I think the great thing about the NIH stroke scale is like if you're trained in it properly, you yourself as a nurse in San Ramon could communicate with somebody in South Africa, and you guys would be on the same page because it's a validated strokes, or it's a validated scale that is this. The idea is for everybody to get a similar score every time that they validate it. For example, when they did the NIHSS trial, there was sites from everywhere in California all the way up and down the coast to all over the world, and they were all trained in NIH stroke scale. And the idea was that no matter where you were going to get a similar score, and so thus the data was reproducible. And like it says here, it's the key is that essentially two independent individuals can assess the same patient and come up with a similar score. And so, when you're calling a provider and you're telling them, no matter whether it's me or you, if you're telling me, hey, points are accumulating on the NIH for this, this, and this, then I know exactly what you're talking about. And I can picture the patient in my mind just over the phone because of this validated trial. So essentially after the trial, it became like a gold standard assessment for stroke. They added like training and certification, which was then why we use it outside of just research for assessment of just stroke. So scale. So the NIH stroke scale, like I said, is a widely used systemic assessment tool that's used to measure neurological deficits. So the severity score ranges anywhere from 0, which is a largely patient with no points on the score. It doesn't mean that they don't have symptoms. It just means they're not scoring any points, all the way to 42, which is generally a comatose patient that's not participating in any of this. So the goal is to have, like I said, multiple examiners at different sites have a score that is consistent. So if you're talking to when I'm talking to the ED and they tell me an NIH stroke scale of 2, I picture a patient very differently than an NIH stroke scale of 17. And as you get more familiar with the score, you're going to actually realize how specific patients I can kind of guess the scores based on seeing the patients. And so this just tells you like severity. Obviously my screenshot gave you something there, but essentially the more severe the score, lower the score, the more tendency towards better functional recovery in the 6-month period after that, right? And the higher the score, the lower the functional recovery was thought to become. Okay, so let's kind of get through it. So I'm not going to go through every single one. So some of them are very basic and I'll just touch on them, but I'm just going to pick on certain parts that I thought and then certain nuances that I think is useful for you guys, but we'll try to go through most of it. So the components of NIH, the first one is going to be like level of consciousness. So what you're doing here is that you're basically, so basically what you're doing is you're asking the patient you're basically asking how alert or awake your patient is at bedside, right? So if they're getting a score, you're basically looking at your patient and assessing how awake they are. So the score of 0 means they're like you and I, they're awake, they are responsive, they're able to answer all your kind of questions. Now, the way that I kind of try to build this up is that you always want to start from the least invasive to the most invasive. So when you walk up to a patient, you shouldn't just go ahead and like shake them right away. Your first thing is going to be like, you're just going to assume that they're normal. So you're going to say, like, hey, Mr. Johnson, how are you doing? And that's just verbal stimulation. They look at you and they respond, hey, I'm doing fine. That patient, and you ask them a couple of orientation questions, they're answering all your questions appropriately. That person is alert. The second thing that you can actually raise to the next is after verbal stimulation is going to something like tactile stimulation. So that means you touch it, like Mr. Johnson's sleepy, but once you kind of stimulate them one time, they arouse and they're able to answer all your questions. So that's tactile stimulation. Sometimes your tactile stimulation have to be repeated shaking. Maybe they're very sleepy because the stroke is larger. The larger the stroke, the less arousable that they're going to be. So you have to shake them a couple of times, and that's going to be something like a 2. Now, a 2 could also be that you also need, so you've gone from verbal to tactile. And if they still are not responding to tactile stimulation, you're going to go up to what is called noxious stimulation, which means something that hurts a little bit. So the patient is still not awake. So you maybe give them a trap squeeze or a squeeze on the shoulder. That's one way to do it. And then maybe they will grimace or look at you and then try to get rid of that stimulation. Other things that I try not to do is nail bed pressure to get people to withdraw. That's very painful, but sometimes you do need it. And sternal rub, meaning rubbing the sternum, is what I use as kind of last resort. So going through the scale a little bit, 0 is, you're basically a score of 0 means that they are very responsive. They are just, responding to you appropriately. 2, a score of 1 means that they are basically, they're sleepy, but if you just touch them a little bit, they're able to awake and answer all your questions. So they're sleepy. So the difference is they're not awake at baseline, but they're sleepy. But when they wake up, they're still conversing somewhat normally. 2 is when we start to get into the stronger tactile or noxious stimulation. We really have to stimulate these patients to wake up, and they may just look at you and they may not answer your question, but at least they open their eyes to some sort of tactile stimulation or noxious stimulation to look at you. And then number 3 is the worst, is essentially like a comatose patient. So the only way you really get a 3 is if essentially you're giving them a lot of stimulation, but they're only going to respond with reflexes or they're completely unresponsive, right? And so we're going to go over a little bit of some of the reflexes that you may expect. So the information that you've gathered with this information is how big the stroke is. Small strokes, even if they're plegic, if there's a small stroke, they're still going to be awake and responsive to you. What happens over the courses of stroke, the first day there's acute stroke, what you can expect on day 2 up to day 3 is swelling of that tissue. Let's say if I bump my arm, I get bruising on my arm. That area, the natural course of tissue that is damaged is to bruise and get swell. And obviously the bruise doesn't appear on day 1, but sometimes day 2, day 3 is when your bruising appears, and the same is in the brain. A patient may be more awake early on in their stroke, but as the days go on, up to day 3, which is the peak of swelling, they may get sleepier, which is when these scores may increase and we may want to re-image. So it's going to give you an idea of size of the stroke, worsening of the stroke if the stroke is getting bigger. And the third one is over the course of days, sometimes people ask me, why is my stroke scale getting larger? Why are they becoming more sleepy? It's because there is swelling or bruising associated with strokes, especially larger ones, and that peaks around day 3 and then it comes down thereafter. All right, so like I said right here, the 3 means that you're giving them like a noxious stimulation, but you're only getting reflexes or no movement, absolutely no movement. So that's just the worst score that you can possibly get. So I'm going to kind of give you guys some of the abnormal reflexes that you can expect on the patient, especially if the stroke scale is quite high. So one is just, you guys have probably heard about this, it's like the Babinski reflex or the plantar reflex. And what you do is you stimulate the bottom of the foot coming from the heel all the way up to the big toe. And what you actually get is, it's cut off here, but the big toe raises up. The big toe raises up. I'm just going to skip over this. Grasp is essentially if you put your hand inside, they start to grasp. And what I kind of explained, so the big thing that patients' families sometimes say, like, hey, they're squeezing my hand, squeezing my hand. I never take squeezing of hand as a command following, because essentially what happens is as you have a worse and worse stroke, what you end up doing is reverting back to primitive reflexes. And if you think about it, what's the first thing that a baby learns to do? Is grasp, right? You put anything in a baby's hand, they will grasp it, they will grasp it. When patients have very, very significant strokes, they revert back to their baby-like reflexes, one of which is a grasp. So if you put anything in their hand, they at times will squeeze onto it. What I like to focus more on is essentially when you're talking about commands, and this helps us with families, like families will say, hey, look, he's squeezing my hand, he's understanding. I usually tell them, like, I like to see, like, if they give me a thumbs up or 2 fingers in response to something, that's more convincing to me than squeezing, because it could just be a grasp reflex. So another important one for you guys to know is this response that's called triple flexion response. And what will happen in larger strokes, let's say somebody is paralyzed on the right arm, right leg, and they're not moving it. Sometimes if the damage is severe, you get a response that is called triple flexion. And what that means is no matter where you stimulate the leg, whether you stimulate it at the knee or you tickle the foot or you tickle the upper thigh, no matter which way you touch it, it always responds the same way, and that's by bending at the hip, flexing at the knee, and bending at the ankle joint here. So it's kind of like, and it will always look the same no matter where you touch the foot from. If you touch the foot from the left, the right, it always moves in the same stereotype way, which is essentially flexion at, I'm just using my arm here, flexion at the hip, the knee, and it will always withdraw like this. And why it's good to know that is always you want to distinguish this from actual withdrawal. So like I said, if I touch his or her foot with a big stroke and it's triple flexion, it always moves in the same way, always moves in the same way, as opposed to, and that's by flexing back and forth. That's opposed to withdrawal, in which you touch it and the foot may move a different way every single time, if it's truly trying to get away from that sensation. It's important for you guys to perhaps maybe know this reflex more so for families in their own education, because families will say, hey, look, he's now moving, or she is now moving that leg. That's a sign of improvement. You know, although you want to be supportive of the family and not be, you know, not bring negativity, or, you know, you're thinking you're encouraging, it is also important to be realistic with them and let them know that this is actually a reflex and may be suggestive of a higher level injury. Sorry here. All right. And again, while we're going over this is a score of 3 on the NIH stroke scale 1A. These are more severe injuries, extensor posturing, which you may see, in which both the legs are extended, including the toes are pointed down, and the arms are internally rotated. And every single time, you may see this more in an anoxic brain injury, means very severe brain injury. And then the second one is decorticate, where they've same positioning of the legs except internally rotated, and these upper arms are flexed. And what this is generally a very poor prognostic sign for us. If we see this, we generally would assume that the patient in the long term will not do too well and may not have the best functional recovery. Okay, moving on to 1B. So here, this is, again, we've level of consciousness, we already reviewed, like how awake is the patient just by looking at them, touching them, and then perhaps with some minor stimulation. So level of consciousness part 2 is essentially looking at, are they oriented? And so here I want to state that the key is just using your words as opposed to showing them or trying to act it out. So what you're going to do is you're going to ask the patient the month, and you're going to ask the patient his or her age, right? And so you don't want to try to stimulate it or try to give them hints. You just want to ask them plainly, you know, what's the month and what's your age? You got to accept only the first answer, and then no partial credit for being close. What we're testing here is essentially language and wakefulness, right? So language is controlled by the left side. And so we have 2 parts of language here. We have the back part, which is close to the ear. And so you think about it, that the words come in, you interpret it. So the words come in, the left side will go ahead and interpret, okay, they are asking me the month. And so that's Wernicke's area. And then you're also testing Broca's area, which is slightly more frontal than that. And that's where you actually produce words. So if you have a problem with either one of these, you're going to not be able to produce the correct answer. So patients, specifically what we're testing here is Broca's, which is the speech. Because if I ask them what's the month, even if they understand and they cannot produce the answer to the question, then we know that they are aphasic and their Broca's area is affected. So you get a 0. That means a 0, the lower the score, the better. 0 means that they got the month right. They got his or her age correctly on the first try. You get 1 out of 2, you get 1 point. And if you get 2 out of 2 incorrect, then essentially you get 2 points, right? So again, here, what we're testing is ability, what you're really testing is ability to interpret, but what you're testing more is ability to then produce speech to be able to answer this question. And here's kind of what I'm talking about. So here we have the left side of the brain, left here. And so up here towards the front is Broca's area. Sounds like Boca, which is your mouth, which is spoken word. And then back here, we have Wernicke's area. So this whole area would be a MCA stroke, right? So in a large MCA stroke, you would score a 2 here because you wouldn't be able to understand and you wouldn't be able to produce produce the spoken speech, right? But the real thing that we're testing here is Broca's area, the ability to produce the answers to the questions while also being able to interpret it via Wernicke's area. Now we go to part 1C, which is a little bit more trying to understand. It's like part one, but this time we're mostly just understanding. So what you're going to do here is that you're going to ask the patient to open and close their eyes, open and close their eyes. And so what you're doing here is, even if they can't speak, they'll be able to understand. And even if they can't speak, they'll be able to follow these commands. The second thing that I don't like at all, that I think that should really change, and I don't actually use it, is they ask the patient to grip and release the unparalyzed hand. The reason why I don't like that is because obviously, I've told you that sometimes if you have a grasp reflex, then you're still going to grasp and you're going to be maybe a little bit confused. I change it up personally. I ask them for a thumbs up. Can you give me a thumbs up, thumbs down, thumbs up? And then I know that they are truly understanding. And again, if you perform both the tasks correctly, you are not going to get dinged at all. Now, why is this important? What we're distinguishing here is Broca's area from Wernicke's. And like I told you, the front area here is spoken language. That means ability to speak. And Wernicke's, which is closer, farther back, is the ability to understand. And what you're doing with question number 2 is you're distinguishing these two areas, right? Because this is, like I told you, this whole area here is the MCA area. Over here in the front, like we said, here in the front is your ability to speak, and back here is your ability to understand. So this is an MCA, right? And if we have MCA, these have branches, M2 branches. And usually what happens is that sometimes you may have a patient who can understand. So here's the stroke in this patient. It's right here in the front part, which is what speech. So this patient would, so the speech is affected, but the ability to understand is preserved, right? So if you told them to open and close their eyes, they'd be able to do it because it doesn't require them to speak, but they would probably get these answers wrong. Does that make sense? So again, we're trying to differentiate the two parts of the MCA. All right, so the next portion that you're going to go into is the gaze, or the gaze preference. I really like eyes. I think eyes tell you a lot about what is going on with a patient. So the first thing you want to do is you want to look at the patient and you want to look at where their primary gaze is. So they're either going to be one way, the other way, or hopefully dead center. So you're looking straight ahead. So for awake patients, you can just tell them, hey, can you look to the left or can you look to the right? Now, some patients obviously are going to be aphasic and they're not going to be able to understand what you're saying. So if they're still awake, what you want to do is you actually just want to go to one side of the room, just go to their right side and call them over there and see if their eyes divert towards you. And then go to the other side and see if their eyes divert towards you so that you get their attention and so they know that they're trying to track you. Obviously, a score of 0 is normal. And so here's a good schematic here. So in this one, the patient has been asked to move their eyes towards that side. So let's say that that's their left. In a normal way, that they are able to move their eyes all the way to the end. And the way that I say that a normal gaze means that the color of their eyes pretty much goes all the way to the side so that there is no white space in between there. So they're able to move their eyes all the way to the side. Now, that's what gets you a good score of 0. A partial gaze means that you are trying to look that way, right? They're trying to look that way, but there's still a lot of white in between their eyes going fully direction. We know, and then the opposite would be that their eyes are just stuck in the other way. The eyes are just stuck the other way and they're not able to move them. And it says they're forced the opposite direction. And why that is because essentially the two areas here in the top part of the brain are called the frontal eye fields right here. And both of them are working continuously, and I'll have an analogy right here. They're continuously working to keep the eyes midline, right? So if I'm continuously keeping my eyes midline like this, what ends up happening is if I have a stroke here, only this side is working and this side is not, it's going to overcome and force your eyes this way. So that's what that is testing. So again, full gaze moves all the way. Partial gaze means you have a little bit of white on both sides, but they're not able to get it all the way. And then you get full movement as a 2, which means it's forced in the opposite way because again, the front portions here in an MCA stroke keep your eyes balanced. They're both giving you signal, but if the signal from one side goes away, then the other side will force you the other way. So this is kind of my airplane propeller kind of analogy, which is very similar to what I was talking about. You're both sides right here on the front, right here, the frontal cortex. It's like a plane. So both of them are flying, or the propellers are going off to keep your eyes straight ahead, right? And let's think about if you have a left-sided stroke, right? So this is my left hand, it stops working. This propeller is the only one working. It will then drive your eyes to go to the other side, right? So if your right side is the only one working, it will drive it to the left, if that makes sense. You will always look towards your paretic side. Now, the other thing is if a patient is not moving their eyes at all, what you can do is something called the oculocephalic reflex. And that's the reason to test that is to see if they have any eye movement at all. So in a patient who is very, very obtunded, they cannot track. They're just obtunded. So what you want to do is that you want to take their head very carefully and rotate it the one direction and rotate it the other direction. And what will end up happening is that if you think about it, if you're focused on the screen right now, your eyes are right here. If I focus on the screen and move my head to the left, you can tell that the eyes still remain here and the eyes are all the way to one end. And if I turn my head the other way, you can tell that the eyes are still fixed on the screen, but my eyes have shifted all the way to one side of my eyes. Now they're at the middle. I turn the patient's neck the other way, and now the eyes have shifted all the way to one side if they're fixed forward. Now, essentially, this only works in patients who are quite sleepy. And if you're changing their head either direction and the eyes are not moving, you would say they have a disrupted oculocephalic reflex. But if they are moving how they should be, even if you're turning the head, you know that those pathways are intact. Like even though they can't move them voluntarily because they're so sleepy, the pathways are actually intact. All right. So moving on, hopefully I'm not going too fast here. Kind of the benefit has kind of been lost in that I can't really ask you guys questions or anything like that, but you know, we're gonna test, we're gonna try our best here. And so the next thing that I like to see is visual fields, and I'll kind of go over how I like to test that. So first, what you want to do is you want to position yourself in front of the patient, right, nose to nose, lined up, right. And what you want to do is first you want to just show them fingers in every direction. Now, the reason why you want to line yourself up is because what I see people tendency to do is you want to line yourself up and you're using yourself as a test, right? Because if you're out here, you yourself can't see it. So obviously the patient can't see it. So if you can see it, the patient can see it, especially if you're putting the fingers in the middle of yourself when you're directly lined up with the patient. The next thing you want to do is, this is the most helpful thing, is you want to line yourself up with the patient and you close one eye and have them close the eye on the same side. So if I'm closing my left eye, I'm looking at the patient, have the patient cover their right eye. So we're both covered here and I'm lining up with the patient. And then what I'm going to do is I'm going to, if this is a circle, these are quadrants. I'm going to test every quadrant. So again, I'm looking at the patient nose to nose, directly lined up. I am then going to cover the same eye that they are covering. And then, you know, I'll show them one finger, two fingers, any number of fingers in each quadrant. And the reason why you're covering one eye is what people accidentally do is they take it out of the visual field, which means, you know, even you can't see that over here. So you're using yourself as a check. So you're using yourself as a check. So as you test one eye as individual, you're simultaneously testing yourself, and you'll notice that, you know, at some point they may lose the vision. And what I like to do is sometimes, you know, you test it here. Hey, you can see this, you can lose it here, you can see this. But then here they'll say, oh, I don't see these fingers, right? And then after that, I will say, okay, there's some sort of problem on this side. I will continue to close my eye and I will wiggle my finger and I will ask them, okay, you know, Mr. Johnson, when do you lose this finger? And then they say, oh, I don't see anymore. And then you come back and you realize that there's a line where they end up losing their visual field. Yeah, and so 0 is no visual loss. 1 is partial, meaning if you split this, if your whole visual field is a circle, partial means, and you split it into this, you have corners, 1, 2, 3, 4. If you have partial, will be you have 1 or 2 quadrants, so a quadrant that is lost, and 3 means that you don't really see anything. So this is kind of what I'm talking about here. If you're looking at each eye is in each quadrant. So you're testing every single quadrant. So a 1 or a 2, 1 is going to be one of these quadrants are gone, and a 3 means that all their vision is kind of gone. So the reason why this is important, because it depends on where the lesion is. If the lesion is in the eyeball itself, that's the only time. If a person has lost, unilateral eye vision, then it's usually an artery going directly to one eye, because the only way you can do that is by cutting it here. The farther you go back, they mix up signals. So let's say if you get, this is probably a common one, if you get something like D, right? So you had a stroke here. In D, what they end up getting is they end up getting quadrants that are cut off, quadrants that are cut off. And what you actually notice that C through D are the actual ones that are going to be representative of stroke. And what you actually notice is that the visual loss is always on the same side of each eye, right? So in C, it's on the same side, same side. So right eye, left eye, right eye. So it's both of these. You have a stroke here. The visual fields on the left of each side are gone, or each quadrant are gone. And it depends where along the pathway we cut this out that we get a different pattern. Now I want to notice something, that here, basically the right eye and the left eye come together here, and then the right eye gives some information to the left and the left eye gives some information to the right, right? And that's why we get both sides. B is the only one that will get you both sides, and the vision in the center is the same. We'll kind of skip over this a little bit. So I just want to give some regard to, we focus a lot on the pupils and the pupil size. A general idea is always to look at symmetry, and some people just have baseline asymmetric pupils, like one is, and that's normal, like have one larger pupil than the other side. That's normal. That's called anisocoria. Generally speaking, small pupils are okay. It's usually medication related, but if they are getting larger or dilated, that's going to be worse than a pinpoint pupil. Now, the reason why that is that if we look at this nerve, this straight nerve that's going back from the eye, if we look at this round circle, the ability to move the eye is in the center of that nerve, in the center of that nerve. But the ability to constrict the eye is on the outside of that nerve, the outside of that nerve. Now, I'm going to tell you why that's important. So the nerves come from this is a person who had a large MCA stroke. So the nerve is coming back here all the way to the back, right? This is mouse, hopefully you can see it. The eye nerve is coming, especially back here, and going all the way back here. So remember that I told you that strokes do swell over time. So on day 1, we have this stroke, this dark area, this MCA stroke. A couple of things we already talked about is that ability to produce speech is in the front, and ability to understand speech is in the back. Now, this is early on in the stroke, right? This is day 1. You can see that by day 3, by day 4, there is swelling that occurs with this stroke. So it will, especially in larger strokes. So again, like you hit your arm, you will get bruising over time. So in this stroke, essentially what's happened is this is very early on. And as day 3, day 4 has occurred, there is swelling. And now you get to the second CT scan and you can see how there's swelling. And because the head is a fixed skull means that there's no space really in there. It can only shift to one side. So as there's swelling, it cannot go outside of the skull, right? As it swells, it cannot go outside the skull. So it starts to shift towards the other side. And that usually peaks around day 3, day 5, and then the swelling comes back down and we'll get back to something like this CT scanner. Now, the reason why I'm going back to this is, again, like I told you, that the third nerve, dilation of the pupil is bad because the third nerve, the ability to constrict the pupil is on the outside ring, not in the middle, but the outside ring. So you can tell that this cranial nerve, it pretty much travels here, and this is where vision is interpreted. So you can see that if the cranial nerve is is right here. As we swell, we push onto it, right? As we swell, this is what I've done. As we swell, we push onto the outside of the nerve. And what will end up happening is that pupil, it will get larger as the swelling gets worse. So although this is not part of the NIH stroke scale, I just like to kind of communicate it with you guys that usually small pupils are okay. But as we start to get swelling and we start to push on that outside, ability to constrict gets affected by swelling, then that pupil on the same side, so left side, left pupil will get larger. Just something to watch. And if you do see something like that, you see your patient getting sleepier and their pupil is getting larger, always something you want to alert your physician to. All right, so this is a similar setting. What's going on here is that the ladies, look at these two pupils. You can clearly see that one side is larger as this large stroke is pushing onto that nerve, the outside of the nerve that controls the ability to get any smaller. All right, so the next thing is everybody's favorite, which is like facial symmetry. So you're going to ask, it's facial droop, which is part of the acronym for stroke that we always give to our patients and families. And so it's in the BFAST. So essentially facial symmetry, what you're going to do is you are going to ask them to show their teeth and close their eyes and see how that affects. Patient has a score of 0. So 0, you always get a 0 if there are no deficits in there. So you get a 1 if there's minor paralysis of the face. So in a stroke, the effect of the face is only going to be, if you divide your face into quadrants, strokes are only from here down. They don't affect the upper face. That's usually Bell's palsy. So you can see in this patient, if you split his face into 4 quadrants, this is a true stroke patient. You can see this is your nasolabial fold on this side, right? That looks pretty crisp, pretty clean. And on this side, you can see that fold is just not as apparent, right? And so that's called mild nasolabial fold flattening, right? Flattening right there. Now, he probably has a 2 because he's also bringing his lip up on this side, but you can see that this lip is not actually going up. So you could have a patient who's able to bring his lip up so the face looks symmetric, but it's this nasolabial fold that we call it's flattened. It's more flattened than less pronounced than the other side. Now, the other thing that you're checking is when you ask them to kind of close their eyes and open your eyes, you're checking this forehead area. You're seeing that this side is symmetric to that side. And what I generally like to look for are these creases. He has good creases across his forehead, good creases across his forehead. Let's take a look at this other individual. Again, his nasolabial fold here is probably, you can't see because he has a mustache, but probably in real life, you could probably see he has good ridges here. This is gone. This right side is going up. This left side is kind of drooped down. And what you notice here is that when he opens his eyes, close your eyes, open your eyes, and act surprised, you can see that the wrinkles on the right side are generally gone, right? So the wrinkles on the right side are generally gone. Like I said, this is typically not a stroke picture. In a stroke picture, it's usually just this lower half of the face that is affected. If it's the upper part, meaning they have no wrinkles up here and their face is droopy, it's usually Bell's palsy. So this right here is a score of a 3. That means you have nothing on the forehead. Upper part of the face and the lower part of the face is paralyzed. This is more of a 2, which means that it's the lower face only, partial paralysis of the lower face. I would say if you just had flattening of his nasolabial fold, we'd have a 1. So again, I just want to hammer home that stroke usually only affects the lower half of the face and not the upper half of the face. All right, this I'm not going to go into too much detail. Everybody loves this. The drift, this is hopefully the easiest part. So what you're asking the patient to do is you will lift up the arm, and this is pronation, but it's usually in a supinated position, and you will ask the patient to extend their arm and hold it there for 10 seconds. 30 seconds is a long time. 10 seconds, right? And the 0 means that they have no movement, minimal movement or drift for the full 10 seconds. Drift means you get a score of 1, which is the next highest if the limb drifts a little bit, but it doesn't go all the way down, right? And so it drifts, but it does not hit the bed. You get a score of 2 if it's drift all the way down and it touches the bed, okay? It touches the bed, but you can still see that there's effort. right? So it's drifting, but they're trying, it's drifting, it eventually hits the bed in that 10-second mark. A score of a 3 means it's on the bed, but you can see that there's something there. They're trying to get it off the bed, but they just can't do it. But there is some effort there. And a score of 4 means there's no effort there, doesn't move at all. The one thing that people will see in the NIH stroke scale, really, they just want your palms to be flat down, flat down. Um, and a lot of times people will have a pronation, which is this way. A lot of times physicians will ask or nurses will ask for palms up, which is fine, But in the NIH stroke scale, we put the palms facing down. Now, the reason why they talk about something called, let me see, the reason why they may ask for you, if you want to assess for subtle weakness that you may not see on exam, ask them to flip your arms around and then hold them up. Although we're not scoring for NIH, if you rest your hands, your natural tendency of your hands is to rest like this. It actually takes some effort to turn them around, because when we're walking like this, right? And that's your natural position. If you ask the patient to flip their arms around and hold them there, and then close their eyes, if whatever arm is actually weak, you'll actually just notice it turn the way down. It may stay up, but then you can notice that there's some what we call pronator drift, means that they just want to go from pronation to supination because there's subtle weakness in that hand. But again, NIH stroke scale is actually straight up ahead. The next thing, to kind of assess is to do the same thing with the legs, same rules. The only thing that's different here is with the arms, we're doing essentially 10 seconds. With the legs, we're only doing 5 seconds. I know it can be difficult with aphasic patients, and usually what I just try to communicate as much as I can with them, try to hold their leg up and just continually hold their leg up until they eventually get it. And try, even if there is no complete understanding, sometimes they will get it when you try to mimic for them. All right, the next thing is essentially heel the shin and limb ataxia, where these patients who have limb ataxia are essentially patients who have strokes that are in the cerebellum, which is the back part of the head, right about here. And that's the area that controls balance and coordination. So what happens in your finger to nose test is that you are going to back away from your patient. You're going to, hopefully, if your patient is able to understand, you're going to ask them to touch their nose and then touch your finger. So as an examiner, you are just moving your finger back and forth. You are asking the patient to essentially touch their nose and then touch your finger, touch their nose. And as you touch their nose, touch your finger, touch your nose, touch your finger. You're assessing their movement. Now, as you move the finger, I'm just going to hold both. As you move the finger, what you want to do is what you're assessing for is how accurately they are touching the finger. You want them to have index finger to index finger. If they're touching it high up on the finger, that's a minus point. If they miss it, that's a minus point. If they miss it, that's a minus point. Now, what you want to do is you want to put that finger as far away from the patient as they can to reach for it. Because if you think about it, if I'm really close, I'm just touching here. That's very, very easy for me, compared to if I move it out, to reach out to it, you need more coordination. And so what you're assessing for is their ability to bring their finger to the tip of their nose. An ataxic patient may miss even their own nose and come over here. And then you're assessing for their ability to touch the tip of your finger and how smoothly that they can do it. And so a point would be, hey, they miss it, or they're very zigzaggy getting to your finger. You want to test both sides. You get a point if it's on one side or the other side. So if you have any unsteadiness, you're going to go ahead and give them a point for that. And again, hold it far away from the examiner. So after they touch it the first time, tell them to touch their nose. Now you move to a different location to see if they still have that ability. And again, 0 is the best score. You're not getting, you're completely normal. 1 would be, hey, it's present on one side, and 2 would be present on both sides. If the patient is unable to understand or paralyzed, then you're going to give them maximum kind of score. Sensory, I'm not going to really get into that much. 0 is there's different levels to sensory as well. So usually what I do is a patient is awake, I just touch them, touch. You feel that on both sides, great, score of 0. The second thing you want to do is maybe get something a little bit sharp. Maybe like sometimes I use tongue depressor, snap it in half, and poke one side. And I ask them if it's different on both sides. So a score of 1, the patient's going to feel if you, usually what I'll ask them is I'll do one side, prick, 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 and prick, 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 prick. And they'll say, I'm not sure. The question that I generally ask them, like, hey, if this is 100%, what percent is this arm? And they may say, hey, that's like 50% of this arm. Like, I feel it a lot more here than I do here. So a score of 1 means that, hey, it's full on one side, and the other side, they have the sensation of it. It's just less than the other side. Like they may just say, oh, it feels dull there, but I feel it. And you get a score of 2, meaning that they are totally unaware that they are touching this side at all. So you could forget poking them. You could really squeeze them and give them maybe, something that would really hurt a normal person that they were not even be aware of it. So a score of 1 would mean that, hey, I know you're touching me, but it just doesn't feel as sharp as the other side. A score of 2 means that I don't feel anything at all. No matter what you do to this side, I don't feel any of it. So again, there are gradations to the way that you can assess somebody. I just first tactile stimulation, second, a little bit more sharper. And then number 3 is something a little bit more invasive, which I try not to do. You want to build it up because you don't want to go to somebody who, is completely intact and give them a pinch when they don't even need it. That is a poor examination technique. All right, so here's next thing, components of neurological exam. You will also often be testing with this picture. So this is a common picture, which I believe they may change soon. So what are you testing in this picture? Number 1, you are testing their ability to understand and then speech, right? So a person has to have good speech, Broca's area, Wernicke's area, to describe to you that there is a woman here, she's washing dishes, the sink is overflowing, the kids are trying to get a cookie jar. So number 1 is testing understanding and speech. The other thing that this is also testing with this stroke card is vision. So very often, if somebody has a visual field neglect, I've seen this very often, the patient will essentially tell you that there's a woman here cleaning dishes and has no idea that there are kids here opening a cookie jar. And then what I tend to do is, if the picture that they're holding it here, I tend to move it into this. So let's say if this visual field is gone, I tend to move the card to the right-hand side. And then they'll say, oh, wow, there are actually 2 kids there. So it's a good technique there. The next thing on there is essentially extinction. And what that is a little more subtle sensory technique. So essentially, extinction generally means that one side is being neglected, or a patient does not actually know that you're touching their side. It's a little bit different than the pure sensory side. So extinction means that when both sides are being stimulated, they don't know that one side is being touched at all. So what I generally do is I have a patient close their eyes, I touch the right, and then I touch the left. So I'll touch the right, I touch the left, and they'll say, okay, you touch my right, you touch my left. And then you want to touch both at the same time. And whatever side they have the stroke on, they won't sense the opposite side. So if I touch the right, they'll say, hey, I'm touching the right, touch the left, now touch both arms. And they'll say, hey, you only touch my right. All right, sorry, I kind of whizzed through that, but what I kind of want to just go over some closing points. The idea is I didn't get through every single part of the stroke code, but I thought I got into a couple of niche details, which will hopefully help you with the patients. And then the idea is to read through the stroke score and try to get the stroke score as close as you can to a number that you think is reliable. Because obviously we rely a lot on the communication from the nurses. And what I like to hear it sometimes is like, hey, Dr. Wally, I saw this patient, the NIH stroke scale has gone up or has gone down, hopefully, for the patient. And what's really helpful for us is to tell us, what is the score? Obviously, if you tell me like 30, I know that's quite a sick patient. Or if you tell me 1, that's quite a sick patient. But the other thing that I like to know is, what did they get the point for? If a patient has NIH stroke scale of 1 because they have a little bit of facial droop, I'm not as worried about a patient who has NIH stroke scale of 1 because they can't talk, or NIH stroke scale of 2 because they're aphasic. So what we like to communicate is, obviously, especially when you're tracking patients, NIH stroke scale at the beginning and the end has been consistent, we're good to go. Or if it's actually increased, and which modalities did it increase? How did it increase? We like that explanation so that we can put in our mind, is there a different area that's being evolved that the patient is getting worse? So that's all I kind of have for you guys. I apologize for not being there in person, but hopefully I'm going to be able to get this video uploaded to Stephanie. So hopefully you guys will be able to watch it. Sorry for not being able to answer questions, but this is my email address. If you guys have any questions, any concerns, feel free to email me. If you see Dr. Yazbek or I rounding, feel free to approach us with any questions or concerns. We're here to help, you know what I mean? Help you guys and help take care of our patient population. So hopefully I will be meeting you guys soon and hopefully in person. But I hope you guys have a good rest of the day, and I will see if this now. If this cancels.